Hello, I'm Dr. Wanda Torres, MD. I am the founder of Suncoast Women's Care, a medical facility renowned for our expertise in women's reproductive health, obstetrics, minimally invasive surgery, and robotic assisted surgery. Join me each week as I interview guests in the top of their fields about the world of OBGYN, exploring the innovations and personal stories that shape our medical experiences. Hello, everyone. Welcome to the series of our podcast, Conversations with Our Physicians and Our Nurse Midwife. Today, we have Dr. Natalia Bukavin, who has joined the Suncoast family. Thank you, Dr. Natalia Bukavin, for being here. And the topic for today is menopause. So, welcome.
Thank you.
So let's start talking about menopause because our patients come with this issue every single day. So let's start with the definition of menopause.
Yeah. So menopause is defined essentially when women stop having periods. The average age is around 51 to 52, but women can really start experiencing symptoms of menopause a lot earlier. At that time, between 4 to 8 years, around 5 years before menopause is the perimenopausal transition. Menopause, the formal definition is not having a period for a year. But of course, that doesn't apply to a lot of women, right? So women who have had a hysterectomy or women who are using a hormonal IUD, who have had an endometrial ablation, then that really doesn't apply to them. And so a big way to define menopause is also by the symptoms that women experience.
So, what are these symptoms that the patients can present? Because we see it a lot. So, let's talk about those symptoms.
Yeah, so I think from the majority of people hear hot flashes and night sweats, right? Those are the common ones that are, we hear about in the media, and there's a lot of symptoms that women might not be aware are related to menopause. And so there's estrogen receptors everywhere in our body, right? So many things can be affected when we lose that estrogen as we age. So, yes, hot flashes and night sweats, those are known as the vasomotor symptoms. But another less commonly known symptom can even be something like palpitations. That can be a vasomotor symptom. There's estrogen receptors in our hair and our skin, and there can be skin dryness or hair loss. In our musculoskeletal system, women can notice that they have a frozen shoulder all of a sudden, and there hasn't been an injury, and they might find themselves going to and getting an extensive workup and not really thinking that it could be from menopause. Sleep problems, problems with libido, problems with vaginal dryness. All of those can be symptoms.
So, there's a multitude of symptoms that we can experience. So, is there a test that we can do for those patients that you mentioned that they had an endometrial ablation? What can we check? What levels?
Yeah, so there is a test that can be useful, but an important thing to remember with any kind of hormonal test is that hormones can change throughout the day, right? So anytime we get a test that is leaning one way or another, it's always important to repeat it. But when thinking about a test, I like to explain to my patients like this, that there are two hormones we can check to see if somebody looks like they're going through menopause. One is follicle stimulating hormone, or FSH. It's produced by our brain, and it works to tell the ovaries to recruit follicles, to produce estrogen, to ovulate. And so then the second hormone we can check is the estrogen, right? So we look at this communication, and if somebody's follicle stimulating hormone is really high, but then their estrogen is low, then that can tell us that their brain is trying to get the ovaries to produce estrogen, and the ovaries are just losing their ability to do so, which can indicate menopause.
So, sometimes we have patients that are younger, that are less than 45 years old, and they can start experiencing these symptoms. I always remind the patients that we need to look into thyroid.
Yes.
So, and also exclude premature menopause. So, what would you tell the patient? How can we exclude this?
Yeah, so premature menopause would be a woman who's experiencing symptoms of menopause, or maybe she's not having menstrual cycles when she previously had cycles, and typically these women would be less than 45 years old. And so in these women, I think doing a history is really important. So learning about, have they had any issues where they've undergone radiation or chemotherapy or any kind of ovarian surgery that might affect the amount of follicles that they have. And then, you could check the same hormones, of course, check their thyroid function. There's another hormone called prolactin that can affect periods that would be really important to check in those women. And then once we get a suspected diagnosis, it can be pretty distressing for women because, they don't know what to expect and they're still so young.
Yeah.
So then I think counseling them on just expectations and what we can do for them is really important too.
So my youngest patient that underwent premature ovarian failure or premature menopause was 28 years old.
So yeah.
So very young. So is everything lost? Because they are going to ask, and I have
Mhm.
children. So what do we do?
Yeah. So all is not lost, right? There are things that can be done for these patients. And it's also important to remember that you cannot just assume that they're infertile or they can't have children, right?
Hmm.
Between
Correct.
5 and 10% of these patients will ovulate spontaneously, maybe not every month, but it's possible. And so
Mhm.
those who don't desire pregnancy should continue to be reminded to use contraception. And then in those women who are not able to conceive spontaneously, pregnancy is still possible through the use of a donor embryo or a donor egg or a gestational carrier. So there are definitely options. For some women, fertility medication might help with recruiting the follicles that they do have
Right.
to help them get pregnant.
So ultimately, the message for our patients, there's alternatives and there's ways that we can manage all of the symptoms and all the presentations. So going to that, how do we manage or treat menopause?
Yeah. The so it I like to say it's a menopause is a problem where we've lost our estrogen, right? That's
Mhm.
the biggest hormone that's responsible for all those symptoms. And so the traditional way of managing menopause is by replacing that through something known as hormone replacement therapy or HRT, as patients might hear it
Mhm.
called. And there's various ways to deliver hormones.
Mhm.
There's also various hormones to deliver. Um, HRT traditionally involves estrogen and progesterone, but it can also involve testosterone
Mhm.
in women for whom, that might be something that they might find helpful.
So, you had just mentioned testosterone. That will help with what symptoms specifically?
Yeah, so for women, it can really help if they're struggling with libido in the
Mhm.
postmenopausal period. Testosterone has other benefits, and women naturally produce testosterone. So saying that testosterone is a male hormone is really not correct.
Mhm.
It helps with maintaining muscle mass, it helps with bone density, but really the proved reason that testosterone is given with HRT is to help with libido problems.
Sometimes we have encountered some of our patients come with unopposed estrogen, and they still have a uterus. So, what are the risks with that?
Yeah. Yes, estrogen is the hormone to replace in menopause. But if you have a uterus, patients, they need to have progesterone because when we only have estrogen acting on the uterus, that can lead the lining to build up and then not be able to shed. And then that potentially opens up the door for some abnormal cells to start forming in the uterus. And of course, the things we would want to prevent is anything like any kind of hyperplasia or precancer or endometrial cancer is something that could happen with unopposed estrogen. And so progesterone is anti-estrogen. It counteracts it and it helps to keep the uterus safe. So anybody who is considering hormone replacement therapy, if they have a uterus, they need to be taking progesterone.
Let's protect that lining. So, another question that our patients present in our office is, Dr. Bukavan, I'm very interested in talking to you about bioidentical hormones. I don't want any synthetic products. So,
Mhm.
how do we approach those patients?
Yeah, so I like to educate them because bioidentical is a term that is commonly used on social media and on the
Mhm.
internet. And patients read this and they, wonder what it is, or it definitely sounds like something that is more natural or more similar. And the majority of hormones that are used for HRT are designed to be identical to the hormones that we produce naturally. Bioidentical is a word that is kind of only used in the common language. It's not really a term that's even used by medical professionals or scientists. All of the hormones that we use, with the exception of a few, are all synthetically derived from things like soy, but they are all designed to be identical to the hormones that we produce.
So, if a patient comes to you and you know how they do all their research and they really, really want to go the bioidentical route, how do you counsel them?
Yeah. So that patient, I would think maybe they're referring to something like pellet therapy, which, we can talk about quickly the ways, how do we administer HRT, right? And then go into pellets. So the traditional ways that's kind of FDA approved traditional HRT is either a pill or it's a patch. It can be, a lozenge, and and then testosterone is usually administered, it can be administered as a cream or as a tablet. Pellet therapy is another way to administer hormone replacement. It involves placing the pellets under the skin, and then they release the hormone at kind of a steady interval. And so some patients might like this type of therapy because, they think it's more natural, or they think it's, the bioidentical hormone, which it's important to remember the hormones that are used are the same. It's just the delivery system that's a little bit different. Another thing that I like to remind the patients is that pellet therapy is, well, it can be really beneficial. And I don't want to say that pellet therapy is, bad or not the right choice for some patients, but it's not one of the options that is FDA approved.
Mhm.
So they are made by compounding pharmacies. The benefit of that is you can combine the hormones in an individualistic way, right? There's more options for the patients. But then it's important to keep in mind that because there's not that FDA regulation, there can be some variation in what the dose that is reported versus the actual dose. And so it's important to monitor those patients for any symptoms that can be related to hormone replacement therapy.
Yes, one other thing that we have seen with the patients with the pellet therapy and the testosterone specifically, they do get more energy and it helps with their libido.
Mhm.
But going into that segue, right? Some of the issues that our menopausal patients have is vaginal atrophy and vaginal dryness. So that translates into painful sexual
Mhm.
intercourse. What can we do for those patients?
Yes. So I tell all my patients who report vaginal dryness, vaginal discomfort, I tell them about vaginal estrogen because I tell them it's like hormone replacement, but it's for your vagina. So vaginal estrogen has been extensively studied, and they've shown that there's minimal, just negligible absorption into the bloodstream. And so it really stays in the vagina. It works to revitalize the vagina. It works to decrease pain with sex. It works to decrease bleeding. The most common cause for postmenopausal bleeding is atrophy,
Mhm.
right? Which can be really concerning for patients, helps to decrease that. Additionally, because the vagina is there, of course, but then the urethra is also all in the female genital area, and vaginal estrogen can benefit there too. So reducing the number of UTIs women get as they age, and even reducing more serious complications of UTIs like urinary sepsis. And I tell women because this stays in the vagina, most women can safely use vaginal estrogen,
Mhm.
even if just other administrations of hormone replacement are contraindicated for them.
So ACOG, the American College of Obstetricians and Gynecologists, they have recommendations into our practice on how to manage menopause. Is there a recommended time limit on being in hormone replacement therapy?
So the short answer is there's not a strict limit. The typical, timeline, and it kind of depends on what the patient and their physician choose together.
Mhm.
So as far as when to start, right? Then the start guideline is more clear. So starting by age 60 or within 10 years of menopause tends to be the safest time to start. Before we get any of those complications that can happen with the lack of estrogen, because in women who develop complications like any heart problems or any like even dementia, estrogen can prevent it before it develops. But then after women develop this complication, giving them estrogen might actually make things worse. But then once women are on estrogen or hormone replacement therapy, estrogen, progesterone, how long to continue it kind of depends on each woman, her risk factors, her desires, how much she's benefiting, and of course, her family history. 5 years seems to be a time when some patients might choose to stop, just because some of the studies did show, they've been studied the side effects for 5 years. We know the risk factors that we suspect within 5 years. And some women decide to stop after that. Some women decide to continue. And I think that that's a choice that a woman and her doctor can make together.
And another question that I always get from the menopausal patients, they are always concerned about the risk of breast cancer and hormones. How do you approach that question?
Yeah, so it's a I love that question because the answer is not really what you expect. Everybody asks, does estrogen cause breast cancer?
Hmm.
And that's not what the studies show. So, in women, when women were looked, two groups of women, one group who took estrogen only, women without a uterus, and then another group who took estrogen and progesterone, and these women were followed. The studies showed that the women who took only estrogen, there was not really an increased risk of breast cancer and potentially a decrease in invasive breast cancer in those women. The group that took estrogen and progesterone, those women, there was a slight increase in breast cancer. So if we're looking at 5 years of being on hormone replacement therapy, the increase was about 3 per 1,000 women. So overall, a low risk.
Agreed. So if a patient, one of my patients desires to continue HRT or ERT, I say as long as we continue doing your mammograms on a yearly basis, I don't have a problem with it.
Yep, I agree.
So another going into menopause and the risk of osteoporosis, which should be another topic on its own. We always have to protect bone health in our menopausal population, as you had discussed before. So besides, walking and exercising, we need to add calcium and vitamin D. Any other recommendations that you have for your patients?
Yeah. So I always tell patients about weight bearing exercise.
Mm-hmm.
So it's not, a lot of patients, I ask all my patients, what do you do for exercise? Do you do any weightlifting? And I notice that a lot of my postmenopausal patients, they're exercising, they're walking, they're doing yoga. Those things are wonderful. But I tell them, I explain osteoporosis is when your bone breaks down faster than it's building back up. And I jokingly say you use it or you lose it, right? So you need to keep putting a little healthy stress on the bone to get it to stay strong.
Mm-hmm.
And so I recommend either weightlifting if that's already something that they have in their schedule. If it's not a part of their routine, I always tell patients about a weighted vest. So if they go on walks, I say add a 5 pound, 10 pound weighted vest.
Mm-hmm.
It'll put that extra stress on your bones to keep them healthy.
Okay. Well, anything else that you would like to discuss about menopause? I think you have covered so many of the topics and so many of the questions. So, anything else that you would like to add about menopause?
I think just in summary, I think it's a topic that's been taboo for a while. And it's also, I became really interested in because it's really not a topic that is widely, taught in even residency, which is such a shame, because it's women spend a third of their life in menopause, right? And it's so important to educate them and teach them that they don't have to suffer, that their symptoms, they're not crazy if they're experiencing certain symptoms, and that there's help for them,
Correct.
safe therapy and ways to make their life better in the last third of their life.
Completely agree with that. So, thank you so much, Dr. Bukavin,
Thank you.
for sharing your expertise in menopause.